introduce the speaker of the evening, Dr. Karunakar. Sir is a MD from AIMS, MNAMS Delhi, and FRCOG from UK and MSc Spain, and he has so much. He's the consultant in reproductive medicine, gynecology, and obstetrics. Patient-centric evidence-based reproductive care provider in UK and UAE for simple or complex male and female infertility, IVF, recurrent IVF failures, and recurrent miscarriage. He has 20 continuous years of experience at UK's largest and most advanced fertility units, and recently he is in UAE in assisted reproductive technology. His working experience with Nobel Prize winner Professor Robert Edwards, world's first IVF center, Bond Hall Clinic, Cambridge, UK. He has diploma in ultrasound, London, certificate of advanced ultrasound skills from King's College, London. He has been co-investigators with Mr. Peter Brinston, Mr. Thomas Matthews, member of International Society of Ultrasound and Obstetrics and Gynecology. He has been fellow of the Royal College of Obstetrician and Gynecologist, member of British Fertility Society, member of American Society for Reproductive Medicine, member of European Society for Human Reproduction and Embryology, member of British Society for Medical and Dental Hypnosis, member of National Academy of Medical Sciences, India. He has been 18 years as trainer, presenter, speaker in UK and GCC at international conferences, hands-on training workshops in USS, in ART, gynecology, early pregnancy and obstetrics. He has audit experience in ART for 10 years and he has so many publications. We are all blessed to have this evening Dr. Karunakar, and we are eager to listen to his scientific deliberation. Over to you, sir, for your scientific deliberation.
Namaste, everyone.
Welcome, Karunakar, sir. Dr. Jyoti, will you like to introduce the subject?
Yeah, thank you so much, Dr. Anita, and it is a marvelous job that you've done. The PCOS series has been wonderful, and with such stalwarts, I feel so very, humbled that I'm also a part of this group. And the topic that has been chosen and about the infertility and ART in PCOS. Actually, PCOS is such a spectrum that it starts right from adolescence till the menopause. It doesn't leave you. And especially during the midlife, that is during the reproductive years, it can play havoc in your lives. And that is what we would like to hear from Karunakar, sir, how he would like to give medication to a PCOS, what would be the criteria if we are doing ovulation induction, when to switch on gonadotrophins, which ones, that is something we all are looking forward to that. So welcome on this platform, sir, and over to you, sir, now. Thank you.
Over to you, sir.
Thank you, everyone. I'm very humbled and I'm delighted to be with those people in Delhi, MAMC particularly. I just went only once to MAMC just to drop some campaigning documents when I was in AIMS 1989. We were just asking for extra hike of funds, senior residency salaries. That was in 1989. I just went in a night and then wanted the support of MAMC people. But obviously, AIMSonians and MAMS were not in beautiful terms with each other. So that's the only exposure I had. And then I had Puneet Bedi from fetal medicine coming back to us. And then Jai Bhagavan Sharma, Sunita was there, and I think Mala is still there in MAMC. So it's just 8692. It's beautiful to be with MAMC flavors around me. If I can move on to share my screen. Again, I start with Namaste, that I try to unite with your expectations. That's what I mean by Namaste. And Eid Mubarak to those who are celebrating this festival as we speak. Obviously, we understand the stress of the couple who needs our help. And their intention is to have something to see in their hands. And idea is for us to work towards that goal. I just wrote as a women for a reason, WO in a pink color and MEN in blue color, because we'll be treating couple, not just ovary, not the androgen problem. And this has been my journey. I would say in Tirupati, I learned a little bit during medicine, just the name, PCO maybe, I just heard the name at that time, and the names, there was a lot of confusion I acquired, how to manage PCO in a busy clinic. For 6 years, there was no IVF. Dr. Kamal Bakshi was trying to do something there at that time between 86 to 92. And then I went and landed up in fetal medicine in UK from 92, where I still stay. But then from 2001, I managed to get into reproductive medicine. So that's where the focus started. So this has been my journey. And whatever I teach today is the one what I acquired basis of Spiroff in AIMS. That's me. And then from Bone Hall, Cambridge. And this is Bone Hall, Dubai. I just recently spent, this is a PCO baby just to share with you. And then right now I'm here at Prime Hospital, which is not a fertility center, but it's a general hospital, and I manage people in 2 fertility clinics in Dubai. And I haven't managed to return back to UK because of COVID. I normally travel between the 2 countries. Now, once we have the knowledge and training and experience, and then there is an equipment that helps us to achieve what we want to, and the integrity to have the appetite for excellence. And excellence means we should be system-driven care providers, we should be quality-centric, and we should check what we have done. Every single thing what we have done, whatever we told the patient, whatever we did the procedure, whatever medication we give, whatever treatment we have done, we should follow, audit. Then comes the issue, the need for unrelenting attitude and unconditional serving, because we always go by terms and conditions. If patient listens to you, you treat them. Otherwise, we don't treat them as good as. So the treatment of whether they have polycystic ovaries or not, whatever be the etiology or pathology at the presentation, the management of a care provider for running the fertility service remains exactly the same. You should have knowledge or your ability to do diagnostic workup to derive that can you study the couple's ability to create an embryo which has got the highest implantation potential, and that is blastocyst with normal euploidy and normal mitochondrial score. If possible, derive that. Second, you should analyze normal uterine receptivity. In general layman terms, her ability to accommodate and feed a baby. I'm assuming there are senior colleagues around me, but I'm thinking my language will be focused towards junior colleagues learning. So I tend to use the language which I use with patients. I always use the same language, which is her ability to accommodate and feed a baby has to be optimal in the green zone. Again, see the interaction between the embryo and endometrium should be optimal. And there are various parameters with which we will get these markers of good interaction between A and B. D, the systemic health, general health, metabolism, BMI, nutrition, and things which shouldn't be there, all should be optimal. So these are the things that is the secrets formulas of success, whether they have polycystic ovary or not. If we can address all of them, you hit very high success rate in polycystic ovarian people. Again, what is the success that you're looking for in polycystic ovary people? Once you know what is your destination, you can work towards finding the right lane, right vehicle, right speed, right momentum, right gaps, and so on. So with transfer of 2 embryos, probably ploid embryos, most of them didn't do euploid embryo transfer in these centers. So by transferring 2 embryos, you should be able to achieve 73% live birth rate, 73 to 75. This paper, again, not very recent. This data is between 2010 to 2013. Interestingly, the women age group of 35 to 40, if you can finish all the embryos you create from one batch of embryos, you should be targeting 68% live birth rate. And if in case you manage to get 10 to 14 eggs from that person, you should be looking for a cumulative live birth rate of 83%. So once we know PCO couple are sitting in front of you, this should be your objective. Once we are clear of objective, you get the confidence and clarity to approach that couple to achieve this one. If in case you want to achieve a success, you should do everything what it takes to prevent a failure. What are the things that prevent you to succeed, whether it's PCO or non-PCO? First of all, our own knowledge of polycystic ovary is quite limited as we speak. Otherwise, there won't be that many journals, that many articles, that many textbooks, that many conferences. It's endless. It's alarming number of publications happen on PCO every month for the last 30, 40 years. We're still struggling to get grips with it, which means there is something that we don't understand. That's why we are still learning more and more about the same thing. Now, the other things which are contributory factor, I will touch base them. A lot of inertia is there, a lot of ignorance is there. Dedication is substandard. There is a bias. I know this, how to do it. I know she's PCO. There's a bit of bias, and there's a lot of commercial interest driven. So there are a lot of things that can really reduce your success rate. I just want to give 4 examples of cases that I managed in the last 3 months, just to give you till date. It's like I get stuck with several cases of PCO, and which means I may not reach seeing a baby in their hand, taking a picture together. This was a frozen embryo transfer. I collected 33 eggs in a PCO lady with an AMH of 18. It's her second IVF, a British lady. And then I did a frozen embryo transfer with a single euploid embryo. She comes with ovaries of 15 centimeters each. She's very tiny, African British. I thought even she has heredity for mole. Why her ovaries looks like 15 centimeters each at the 12 weeks pregnancy? So the hyper-responsiveness of the ovary without giving any drop of HCG, it's a frozen embryo transfer. This is a puzzle to me. I literally thought it's a GTD. Just giving an example, this happened in the last month. And asked my Allen Institute colleagues to help me, is it a H mole or not? This lady, again, a case of polycystic ovary. She came for an IVF to Bone Hall, Cambridge, 2003. At the time I was doing a collection, I wasn't too happy with the endometrium. I used embryo culture fluid into the uterine cavity. I did a contrast scan. I found endometrium is suboptimal, polypoidal appearance. So I wasn't too keen to transfer embryos at that time, but she was quite upset because she underwent multiple polypectomy, one of the best surgeons in Turkey, few months before she came to Bone Hall, Cambridge, UK. She showed me the DVD at that time to say 6 to 7 polyps were resected a few months ago. So what are you talking about, doctor? Obviously, 2001, I joined into fertility, and it was 2003. My medical director came, Karunakar, you are too junior in this field. Don't try to overdiagnose many things. Again, he's an Indian senior. Obviously, senior-junior hierarchy works wherever you go. So I did embryo transfer. She didn't get pregnant, and she came back to my room to say, what do you want to do? So I said, let's do hysteroscopy. I did the hysteroscopy. It's exactly look-alike picture, which was she had 6 months ago when she underwent multiple polypectomy with operative hysteroscope in Turkey. I just used GnRH analog for 12 cycles for her, induced hystertrophy. Perhaps they softened the polyps and they fell off. Natural conception. She keeps sending her daughter's picture to me. So the problem with her was she was ovulatory. PCO sperm was normal, tubes were patent. There's nothing wrong with her B and C or A or A. It was the B that was at fault. B means uterine receptivity. So I didn't do her IVF. All right. So I'm just sharing this example. That's one. This lady again, she had few collections. Every time we tried to do frozen embryo transfer, endometrium never get downregulated. She has been branded as failed to downregulate because you give GnRH analog. This was the time, 2004, 2005, Bone Hall, Cambridge, where we were not using anything other than downregulated cycles, agonists. So despite downregulation, estrogen being around 10 or 15 picogram, endometrium is always thicker than 8 millimeter. So when I scoped her, this is the findings you have. A calcification, atrophic changes in some areas. There was abnormal blood vessels. When we took a sample, it was endometrial hyperplasia with focal atypia. She was, I think, from Pakistan, living in Bradford area, which is the Cambridge belt where Bone Hall Clinic was there. Obviously, when patient comes for fertility or seeking pregnancy, and then you tell them there is a precancer changes, they're going to oblivion. So she just hid herself for 6 months. She landed up with endometrial carcinoma and she underwent hysterectomy, according to the local doctor. This patient is a consultant in East Anglia. Some of you, my colleagues, know the place. And she had 6 or 7 IUI failures. She came for IVF to Bone Hall, Cambridge. When I scanned her mid-cycle, endometrium did not look optimal. What I expect an endometrium in the window of implantation is the left bottom picture, this one. So, but instead, in the week 3 of, I saw almost like a cave with multiple polypoidal appearance of endometrium. Again, I was hesitant to force egg into a sperm or create an embryo and claim that IVF is the treatment for this patient. I just gave her medical curettage. Again, fond of Dufeston, fond of Dewhurst from AIMS, my days with Dr. Vijayalakshmi Bhargava, Professor Vijayalakshmi Bhargava. So Dufeston those days we were giving as a medical curettage, day 5 to day 25, 20 milligrams. I think we gave her 4 to 6 cycles. Once again, it's a IUI pregnancy for this doctor, colleague of gynecologist. So depending on your setting, primary or secondary or tertiary assisted conception setting, you can choose what medication, what resources you have, what level of expectation the patient has on her resources. Accordingly, you run your service. You cannot ape others. You cannot ape protocols. You just need to be meaningful to the resources that you have, knowledge you have, equipment you have, patients that you have, the profile of the patients, and so on. Your consultation should be extraordinarily thorough. I will share documents, anyone interested, the exhaustive history taking, consultation details of couples with infertility, may it be polycystic ovary, may it be 10 IVF failure, may it be 20 miscarriages before. The history taking remains the same. The way you select your medication and patient compliance has to be addressed by yourself, because patient has to develop confidence with you. You should have means of monitoring the response of the medication or intervention that you chose to find it optimal. You should be flexible enough to alter the medication. You can't be just rigid or frozen in attitude. I will give this. No, you should be flexible to alter the medication and treatment options. You should have the means and expertise to monitor the complications and the medication that you're going to put on. And then when things go wrong, you should have a system how to fall back on, so that overall well-being of a healthy woman or couple coming to your room don't return as a sick people to ICUs. Objectives are exactly the same. The predominant problem the PCO patient suffers is the oligo-ovulation or anovulation, with or without other phenotypic abnormalities, which is amenorrhea, oligomenorrhea, metrorrhagia. How do you manage? Either you just address the ovary and ovulation factor with the luteal support. There may be uterine endometrial pathology related or attributed or complicated by endocrine dysfunction of the polycystic ovary. There may be uterine pulsatility indices abnormality, including reverse diastolic flow. There may be other occult uterine receptivity defects, or it may be non-fertility related implications that she may have. And metabolic dysfunction is extremely inherent to polycystic ovary people, and the general health may be at questionable level. We all know the prevalence of polycystic ovaries. We should stick to some sort of definition so that whatever audit you did, presentations you're going to do, discuss with your peers, publish and follow it up. To be a credible speaker or a credible researcher in an international scenario, you need to follow the international set of definitions and glossary. You can follow mainly the Rotterdam criteria. Everything else is downplayed in the last 30 years. Rotterdam criteria stuck on the top. Whatever I'm mentioning in this lecture and whatever discussion we do thereafter will be just taking some extracts from National Institute of Health. There are a couple of publications. They're older, but just to touch base, how young the people are getting into this metabolic disorder. We call it polycystic ovary on the superficially as a tip of iceberg, but it is just a metabolic dysfunction with our modern lifestyle, even setting up at the age of 9 to 11. Of course, it travels through the adolescency and young adulthood. And again, I'm going to refer to only this, the most recent PNAS review on 2020. American Association of Family Physicians. One of the most patient-friendly or public-friendly infographics, patient information sheet, health information sheet, medical information sheets on the entity of polycystic ovary, how to manage them, how to preempt the long-term sequelae, including their adulthood and then late age, including endometrial carcinoma. They're all been beautifully scripted in multiple international languages by Women Health Organization. Anyone interested, I can share these links. It's amazing that how much effort these governing bodies across the globe are putting to help women, to empower them, and to healthcare providers to act preemptively rather than becoming a medical care providers. They are expecting all of us to be healthcare providers, which means just get them too early, like one of my colleagues in the introduction has mentioned. Of course, I'll touch with Royal College of Australian GPs Society. Monash University is very excellent people in the ART. On the backdrop, they're working a lot. Of course, we will be working on 2020 literature. We all know it starts very early, and we need to know if anybody's interested, our colleagues, what to do in the teenage or young adulthood, what they pick up. There are, in UK, it's extremely common, GPs put them on birth control pills as soon as they see a bit of extra hair, acne, oily skin, and irregular cycles. You know, it's very common. We have young women's clinic concept in UK. I'm sure that will take shape in Asia also, that a lot of people have already, before you see them as an infertility patient, a lot of doctors must have done something to them. So history taking should include that. Of course, they will give you a better profile of a patient if some doctors has worked 10 years before you came as an infertility service provider. I just want to draw the attention. People are recognizing the anxiety and depression and eating disorders suffered by these people. If they have been suffering 10 years of before they met you in your infertility clinic, and 10 years there was a problem going on, not addressed, not well managed, your success in 2 weeks, a magical antagonist protocol, is not going to yield results. Preceding 10 years of pathology dictates how your 2 weeks of treatment is going to succeed. So please be mindful of the fact. And people have recognized already, and they're asking healthy lifestyle interventions from the beginning. Once again, even there are people putting them on metformin even before they become married. So in summary, why do they see as an infertility people? They may just need luteal support. Everything else is good with them. That's fine. You just do that, they get pregnant. Or they may not ovulate and they may not produce enough progesterone. Okay, help them to ovulate. Then give them some luteal support. That's all they need. Mind our business, we stop there. Or there may be mild male factor, or they may think IUI is going to increase the pregnancy rate. We'll discuss that another slide. That then you do IUI as well as maintain the luteal support. Maybe it doesn't work. 4 to 6 IUI cycle. Then go ahead with IVF or IVF with ICSI, depending on the male factor or zona factor. Or some people in our part of the world, there are a couple who are coming to us. Doctor, we want to have a boy and a girl at the same time. They never even tried. That's all we are doing in this part of the world. So I'm just giving overall experience that I went through in the last 30 years in treating people with PCO. Without endometrial improvement, and at times, at least addressing reverse diastolic flow, without identifying thrombophilia, which might contribute to multiple IVF failure, multiple miscarriages, some clever doctor after 5 IVF failure tell you, nobody checked you for this. No, let's not give a chance to any other doctor anymore. After this lecture, you pay attention to what are all the things that's going to stop the couple, to begin with, the couple fail to achieve a pregnancy, because 20% of PCO people are having normal size family. They may never get to see a gynecologist, or sometimes they see with menometrorrhagia in later life, or any other gynecological pathology linked to PCO. But there is a lot of things are right with polycystic people in most of the people. But in some people, you may do something which is you're missing the thrombophilia, you're missing the immune intolerance, you're not going to succeed. So these are the medical list of things that you may play a role in achieving the parenthood to the PCO people. Surgically, you may have to do ovarian endometriotomy, bariatric surgery. We never ever ignore there is a complete couple that you are treating, women, not just PCO. You're not dealing polycystic ovary. You're not treating a diagnosis. You're treating a couple. Male factor has to be addressed, diagnosed, improved properly. Tubal factor has to be diagnosed, managed, improved, and couple financial situation, emotional situation, sexual dysfunction, depression. Every single thing has to be addressed if you're providing a high quality service. But you need to know, is there a protocol you can just grab and follow for each couple? No, there are guidelines. Each couple may require a different approach. It comes with experience, but you need to be mindful that there are so many committees and guidelines, countless of them, and they clearly say people are just underestimating, overestimating the diagnosis. Many people come, I was told Dr. PCO, now you tell them today it's no PCO. They dislike both doctors. Don't think we are clever by disputing another clinician's diagnosis of PCO, PCOS, PCOD. Doesn't matter what names and titles we give. There is always one doctor giving a different opinion. Secondly, the management is not consistent, it's highly inconsistent. Third, the women's expectations are different than the doctor's offerings. And then there is a gap in evidence practices. So this is a reality. We are in the field of reality check. Therefore, if you see, there are 31 evidence-based recommendations, 59 clinical consensus recommendations, 76 clinical practice points. You're not going to get joy by just reading and attending conferences, course after courses, to manage a couple sitting in front of you in your infertility clinic. Again, if you're a primary care setting, secondary care setting, you're going to be stuffed. You will only dispose what you have. So there is no substitute for standardized approach to infertile couple, whether or not PCO. This is the sheets I designed and I follow. Page 1 and page 2, every couple is given page 1 and 2. 1 includes what are all the 10 things in a male that stops him to become a father? What are the 10 things in a female that stops her to become a mother? What, as a couple, example, fertilization. It's a couple business, not on the sperm's own agenda or the oocyte's own agenda. As a couple, certain things has to go well. So you identify what as a couple factors you need to analyze. What are all the tests? For us, IVF is a diagnostic test. ICSI and IVF split is a diagnostic test. IMSI is a diagnostic test. PICSI is also a diagnostic test. Polar body biopsy to analyze the ploidy of the oocyte is also a diagnostic test. Pre-implantation genetic screening is a test. Recurrent implantation failure, whether or not PCO, is also a diagnostic test. In this page, you're only diagnosing the problem of the couple in front of you who failed to become parents naturally or with the help that they have done with the other organization before they came to you. Then comes treatment or recommendation or what next, what are you going to do? More or less all PCO couple, more or less all the doors are open if they're truly PCO and they're young PCO. Natural methods with timed intercourse, you just guide them. Ovulation induction with timed intercourse or ovulation induction with IUI, IVF with ICSI, IVF with pre-implantation genetic screening. You may use laparoscopy. You may need to do hysteroscopy. There is associated pathologies either for diagnosis or treatment. And you must be mindful of the fact A means embryo, B means uterine factor, C means a beautiful and successful and supportive relationship between embryo and endometrium. There is no substitute for comprehensive approach. Smoking is very common in this part of the world. They smoke shisha. They only smoke once in a week, and each shisha equals to 200 cigarettes. It's disastrous part of the world, shisha. So weight, I dominate my discussion on fat loss rather than weight loss because I practice in Harley Street, London. I see bodybuilder women, their BMI is 30, everything is muscle. Their metabolism is so high, they can eat 4,000 calories, they lose weight because their ability to metabolize whatever calories, they just combust them with highest efficiency. So it's not the weight, it's the fat loss that you need to concentrate. Again, male, and never ignore a male. I will address that even in PCO. His weight affects the success rate in your ovulation induction, in your IUI, in your IVF for a PCO people. Let's not be tubular vision. Let's not be horse's vision. That's where I find why PCO has been carelessly approached is we just If you emphasize too much on Clomid, letrozole, Menopur, Gonal-F. This is it. Quite narrow visual approach. Then there is eligibility criteria for every lane or every row that you want to offer. They need to meet this eligibility criteria for them to offer this treatment lane. They need to meet eligibility criteria on this cell for them to have success through this lane. So we just need to have it. Again, as a clinician, you can say, okay, these are all the options, but as a clinician, you can give your own opinion at the end. Write it, give it to them, keep one in the folder of medical records. So couple has the choice. They have been worked up. They had a complete understanding of what are all the tests, what are all the things that may be stopping them, not just PCO, not just one condition, there may be other things. And then you've given them treatment option. You write the cost, you write the logistics and give it to them. Let them think, they will come back to you. I engage one-stop fertility assessment model for even PCO. It makes no difference. You minimize the number of visits, maximize the amount of information that you get. That's what I call one-stop infertility assessment clinic or service. That includes structured history taking, mid-cycle scan, endocrine workup, endometrial assessment, myometrial assessment, uterine artery PI, tubal patency test with I call air contrast salpingography. I'll show quickly something. And then, of course, male workup, semen analysis by a credible andrologist, if necessary, andrology workup, if necessary, scrotal Doppler, if necessary, take a fine needle aspiration. All can be done in a single visit. If you arranged a system, you thought through, you did a good brainstorming, this can be constructed at least in the tertiary care setting wherever you're practicing. Then you go to the next lane of option. What are all the things you can assess further up? Maybe 1 to 2 visits, you will get to see it. And I shared this document, which is the page 2 again. Every couple, if I'm managing a PCO or non-PCO, I will talk to them. What are all the things I should do from month 1 to month 6 or month 12 as a team member with the wife, husband, or their kith and kin, the closest people, closest family member who has a positive impact on compliance of the treatment that I'm going to advocate. We form a team and we discuss, how do I get to have 90% chance of this couple becoming parents? That's all I'm interested. Over the years, my consultations, my approach, my care plan, pathways, everything is, how do I make 90% probability of them becoming pregnant with least obstetric complications with a singleton pregnancy, with least chance of cesarean delivery, for example. That's my target. If it is, as you can see, timed intercourse, it will take 12 months. If you're doing ovulation induction, it may take 9 cycles. If you're doing IUI, you may take 9 cycles to get to 77% of cumulative pregnancy rate. Even with IVF, it takes 2 to 3 batches of eggs to reach to 90% cumulative live birth rate. If PGT, as I explained before, best centers time and again has proved in the last 10 years, take-home baby rate or live birth rate can hit 80% to 90% in green profile patients. And of course, there is a mechanism where you can do the prognostic stratification of this couple by doing the prognostic system. If I haven't shown this slide already. I just make sure I shared that slide at some point. Prognostication, so I'll come to that. So basically, whatever tests you do, you're going to come and explain to the patient in a layman language her ability to create a baby with a healthy sperm without much DNA disintegration, and also some sort of clues as to MH, antral follicle count, myometrial normality, endometrial normality, general well-being is good, age is in her favor, putting all of them, put them into green category, which means the likelihood that she needs donor eggs is very low. Same way, ability to accommodate is myometrial normality, endometrial normality, and nurturing, that is an interaction between them. Again, in the red prognosis category, she may land up with surrogacy. I will explain even PCO people, some of them will land up in surrogacy. And then red category for the accommodate means they may have associated adenomyosis, associated myometrial pathologies. They may land up with uterine receptivity problem, and there may be immune intolerance or thrombophilia. So I address every factor, no matter what they have, PCO or not. Typically, we land up in addressing this bottom left slide, which is 60 to 90 days, or some claim 120 days it takes for the cohort of the follicles starting and land up in a monofollicular ovulation. All the IVF fertility experts are joining on week 11 to 12 of a journey of a follicle. Again, if in the history taking, if you're a male, it's easy for a male to share with you that they're not having intercourse. It's not unusual in a PCO couple. They don't have an intercourse. If they're not having regular ejaculation, the male, the DNA integrity goes for a toss. We have enough papers and scientific evidence to say. So then even just counseling them and then having a regular intercourse may be all that you need to do in a PCO people. Okay, so is there a genetic defect in PCO people? People always ask, I did IVF, it didn't work. They got immature eggs. So there is always, we wonder. There is no way to rule out that possibility now, but as yet, we don't have the right tool to say, is there any compromise in the oocyte competency? Definitely, there is enough evidence to say there is no higher prevalence of aneuploidy of the polar bodies in the oocytes that's been collected from polycystic ovary people. We have references, anyone interested, I can share. So there is no genetic abnormality in PCO people. So let's not blame the oocyte that there is a problem with competency. As I mentioned before, I tend to call everybody in the mid-cycle. Obviously, that's for the one-stop fertility assessment service. And those people who don't have regular cycles, or they have a year with no period, or 3 cycles in a year, there is something that you just call them randomly, check if there is endometrium. If not, you want to assess the endometrial normality, either you induce ovulation and check the response and then do the endometrial assessment, or you give 2 weeks worth of estrogen, like a frozen embryo transfer preparation, so that you can assess the endometrial normality. It's not assessment of ovary. You need to assess all of them. This grading of endometrium I introduced in Bone Hall, Cambridge, after I started the concurrent service for uterine factor assessment, where we did his 2D scan, 2D contrast scan, vaginoscopic hysteroscopy in the mid-cycle to luteal phase, and then histopathology. Having received the histopathology report, I have formulated this grade A grading system of endometrium for a IVF units or a fertility centers. Grade A, early proliferative phase. Grade B, late proliferative phase. Grade C, early luteal and late luteal. This is histology based. Can you assess uterine malformation to a reasonable degree of accuracy in your one-stop fertility assessment for a PCO people? PCO doesn't exclude the possibility of uterine pathologies. So you just activate it, you can see instantaneously what are the malformation. You don't need MRI anymore. Is it difficult to diagnose polycystic ovary? It should be trained, and if you don't have training, you should receive a training. You should have high degree of accuracy to diagnose the size of the ovary or the number of antral follicles between 2 to 9 millimeters. What is a pathology? Can we fix a pathology? We are struggling. We are learning how to manage the pathology. What we are doing now is we are bypassing the pathology. We are just going for a cure. We are not addressing the pathology. So find and fix approach is difficult. Patient compliance is low. The pathology happened 20 years. You only have 20 days before which patient goes to some other IVF clinic or some other fertility expert, or she goes to Google doctor. Within 20 days, you are supposed to do miracles with PCO. So you are hard pressed for time. You tend to jump into treatment straight on. So we can't fix pathology. For those people where it helps, not my colleagues who know everything about PCOS pathology, I tend to say this to my patients if they ask me that, well, the GnRH pulsatility is very high. I just even sing a song in front of them instead of sa re ga ma in the note, sa re ga ma. It comes so frequent, so quickly, that yields higher LH pulsatility compared to relatively lower pulsatility of FSH. This rhythm leads to higher androgen dominant intra-ovarian environment. It's almost like intratesticular environment is given in the ovary, where the cholesterol is stopped at the level of C19 from C27, go through C21 progesterone, pregnenolone, and then go through C19 steroids, but it gets arrested instead of resulting in the ultimate femininity hormone estradiol. It just stops at the level of masculinity hormone, androstenedione and testosterone. So that is the core problem of polycystic ovary endocrine dysfunction. It leads to higher intra-ovarian androgen dominant environment. Obviously, it wants to behave like testis instead of ovary. So what does it do? Follicular atresia, decreasing the selection of the follicles with anovulation, progesterone reduction or absence, and any drugs you try to play with towards a candidate ovary or ovaries been suffering temperamentalness or distortion or disorderliness for 10 years, 20 years. You can't fix them in 10, 20 days. So you need to take a step back, minimum 3 months before you treat a patient with PCO, whatever medication, whatever IVF you want to do. That's the only way. It may take 3 to 6 months before you get the BMI right, metabolic dysfunction right, insulin resistance right, but so be it, because they have a decent ovarian reserve. Again, after weight loss, which is the fundamental core principle of management of PCO, first and foremost principle, many people just weight loss, they get pregnant. They will be just thankful to you forever. But even this littlest of more than 5 to 10% weight, 30% of them can fall pregnant. And nutrients enrichments for 70 to 90 days should be your fundamental approach. So you should help them 90 to 120 days before you expect this oocyte to be competent enough to create a euploid embryo with good epigenetics, good endometrium, good endometrial receptivity, and so on to conceive. So what should be happening? 60 to 80 applicants, 20 for the interview, 1 gets the job. Here, everybody thinks they got a job, and everybody stays, nobody does the job. Once we know, I mean, I've been brainwashed by my Calcutta colleagues, West Bengal colleagues in Allen Institute. They always know more than me. Somehow they put me into the stage. Even if I read Leon Spiroff at that time, 10 times, I was not as good as my Bengal colleagues those days in AIMS. They always knew something more than me. So it was just pushing me. Till date, I'm just learning endocrinology because I'm always scared somebody else knows more than me. And it looks like the publications that I get, number of treatments that are available for PCO, number of new things that's happening. It's just, I hide myself in a corner. When am I going to know a bit better management of PCO people? There is always something new, something better, something more people are doing it. So this is on my table for the last 20 years. This sheet is one of the medical rep thing. How do you differentiate between PCO and PCOS? We already looked at the criteria. Please take effort to know what is the normal level of testosterone, DHEAs, and androstenedione, because you need to measure androstenedione also if you are pedantic about diagnosing PCOS or PCO only. It's academic. They came for a child. They don't want to know they have PCO or PCOD or PCOS. They don't want to know what title you want to give. They came for a child. By checking testosterone, are you going to increase the chance of live birth rate? I question that. It's not the point. So we are practitioners and we are here to give children to these people. This is important, but I don't think I'm, talking to my colleagues here. I'm mainly talking to those people who want to give children in their clinic, not just academically discuss what are all the theoretical benefits. Whenever you find extra testosterone, by testing it, make sure you are not missing adrenal pathologies. That's all I want to emphasize. My ultrasound, I'm very particular about looking at around 28 different things in an ultrasound, whether it is 2D, 3D, contrast scan, doesn't matter. I'm not sure I have time to go through ultrasound in ART as a separate lecture, but you should be able to be writing she has polycystic ovary or not, right and left. You should commit that she's going to be hyper-responder or not. And you should commit that endometrium secondary to endocrine dysfunction of the polycystic ovary is evident to you on scanning or not. If necessary, do the contrast scan. If necessary, schedule the patient for hysteroscopy. And there may be an indication for laparoscopy and uterine artery pulsatility index. So I put an effort into it. What is missing in these people? Why we struggle to achieve easy ovulation, easy controlled ovarian stimulation, easy controlled ovarian hyperstimulation, lowest risk of hyperstimulation syndrome? Because the window of follicular dominant follicle selection is disturbed for large number of months or years in this couple. So you need to put more effort than usual to get this dominant follicle selection if you are particularly treating a PCO people for monofollicular development. If you are looking for 1 to 3 follicle, which is called controlled ovarian stimulation, you need to have this good knowledge of it, which medication will give it. Unless you try, you're not going to be wiser. You can't just follow textbook or this conference or this lecture, this presentation on YouTube video to expect the person in front of you going to respond just because it responded to somebody else. Somebody else is somebody else. Now, when you're giving ovulation trigger, this is what is happening. Diploid is becoming haploid. You can't see this on ultrasound. Many times people are asking me, I'm giving trigger, she is not ovulating. This is a common symptom. I never had to scan a patient to confirm ovulation in my career. I never had to. It's not a practice, at least in UK. But I've done so many webinars, people keep asking, I've given this trigger, sir, she's not ovulating. There is no free fluid. It's not what you're seeing. The completion of the second meiosis is what is happening after you give the trigger. It's not a balloon that's rupturing that you can document on ultrasound scan. There are 4 types of endocrine changes within the endometrium, depending on the ovulatory status of the ovary. Somebody who's fertile with 5 children running around, who never know what she has PCO, doctor only knows she has PCO, but she has no problem. That she's ovulating, she has a sufficient levels of estrogen, progesterone, both in the proliferative phase, she ovulated, and then she has good luteal phase estrogen, progesterone level, and she doesn't have any endometrial abnormality. These are the fertile PCO people. So the endometrium will be great. Second, they're oligo-ovulation or anovulation. So less progesterone or no progesterone. You need to treat them uniquely in that particular way. Third, no ovulation whatsoever. There is enough estrogen. Maybe highest proliferative phase endometrial hyperplasia may be there. That's type 3. Type 4. There is no estrogen. There is no proliferative phase. There is no ovulation. There is no luteal phase. My colleague, again from Alanya Institute, psychiatrist, they're also from South India, they're in States. For 8 years, I knew they got married. She never had a menstruation. They have 3 children, though. She just ovulates one fine day. Sperm is there. She catches pregnancy, and she goes 9 months amenorrhea, and then 6 to 9 months breastfeeding, and then an ovulation because she's PCO. Again, they're having regular alternate day intercourse. 2-3 years later, she catches pregnancy because the month he ovulated, there was a sperm. So second child happened. They kept on asking because I was a gynecologist and he was a psychiatrist. Obviously, there will be debate between us. He was my close friend. He was asking, my wife never ovulates, but she gets pregnant. Can you explain to me? Obviously, till date, I can't explain. That makes him psychiatrist. That makes me gynecologist managing PCO. So endometrial suboptimalness you can see very regularly, and PCO can be easily seen. Sometimes it's difficult if there are adhesions and so on. As I said, reverse diastolic flow is the only one that take it as a serious notice because diastolic notch is very common. Absent diastolic flow is also regularly common, or low diastolic flow is very common in PCO people. But the minute they have ovulation, when the progesterone level crosses 12 to 20 nanograms, something beautiful happens naturally. So I don't just treat tests. I know I used to do that when I was at an institute or an academic institute. Every pathology I used to jump and pick it up. I used to blame patients. They have this disease, that disorder, this disorder. I used to feel very excited. Now I treat couple as humans. So can hysteroscopy show anything unusual about PCO? I'm just showing for the completion's sake. If we don't see the trilaminar appearance in the proliferative phase or at the time of ovulation, or we are giving 10 days of Clomid or letrozole, you never see trilaminar, but endometrium looks like an elephant. Okay, even the myometrial thickness is smaller than the endometrial thickness. It's not unusual. So if you put a atraumatically hysteroscopy, vaginoscopic hysteroscopy, you may see endometrial edema in the anterior wall. You may see just a proliferative posterior wall. This white spots like thing, that are the mouths of the glands. You can see edema here. You don't see the same. I am putting a telescope in the same uterus at the same time at the time of scanning. So I have world's second largest data to share confidently with you. These are all the people with 3 to 5 IVF failure. And I started in Bone Hall, Cambridge, the hysteroscopy service, office hysteroscopy service in 2002, 2003, within a year of me joining fertility center. So we found out there is something unusual in the endometrium rather than just blaming them on ovulation. So you need to address both of them to have 80 to 90% cumulative pregnancy rate. This is just an example that normal late proliferative, the endometrium should look like this, but here it looks like telangiectasis. You're given 12 milligram of estrogen in a frozen cycle. There is no endometrial growth whatsoever. Estrogen may be high because this endometrium almost suffered absent periods for 10 years. It's very difficult for them to come back to a rhythm within 2 weeks. But then if you do it for several cycles, this endometrium behaves beautifully because stem cells are there. Basal endometrium is there. Again, as soon as I do the mid-cycle scan as a one-stop fertility assessment, if the endometrium looks suboptimal, I go ahead and do contrast scan. You can put any liquid which is endometrial friendly, saline, water, exam gel, embryo culture fluid, but don't put air. Don't put any balloon so that it doesn't take the space of lower 1/3 of the endometrial cavity. So you have any cannula that just goes, the tip goes beyond the internal os, prime that catheter and put a bit of saline, see that the saline stays in the uterus and do the scanning. You can see polypoidal endometrium. Polyp and polypoidal endometrium have different origin. The management is different and the prognosis is different. This I already shown. This is fleshy polyps. After surgery also they can recur. You need to manage differently. This is the poor luteal phase or luteal phase defect. Her progesterone was, serum progesterone was about 5 nanograms. So this is poor luteal phase. Just a luteal phase support alone is enough. On the other hand, thin endometrium, I adapt thin endometrium protocol. There are 4 types of thin endometrium in PCO people. It may be relevant or not relevant. You always do the gold standard test if there is a thin endometrium. Thin, if you don't even have estrogen, it's not a rocket science. If there is no estrogen, there will be thin endometrium. So give estrogen for 2 weeks. Make sure estrogen is in the blood, do the blood test. Make sure the blood flow is there. Still the endometrium doesn't grow. Go ahead with hysteroscope. There are 4 types of thin endometrium. Thin and healthy, thin and partially healthy, thin and endometrial sclerosis, thin and Asherman syndrome. You manage them according to the stratification of the diagnosis. What can you do with this people when they come to you? What is the overall protocol or guidelines? I won't say protocol anymore. I'll call guidelines. First line is non-pharmacological management of infertility. All right. This is an old flowchart or algorithm. First line is again lifestyle interventions. First line pharmacological management, clomiphene or letrozole. Dose start 50 and go on. Metformin, yes, I will give the references. BMI, obviously metformin helps for BMI and indirectly accentuates the response to the other estrogen isomers. Gonadotropins, in Bone Hall, Cambridge, we rarely used clomid or letrozole. We went ahead with gonadotropins. There are 2 reasons for that. Our company at that time was owned by Serano, who was manufacturing guanidine. So we had very good rebate. And secondly, you don't need to go and beg the pituitary to give you a bit of FSH LH to talk to ovary to cause ovulation. You can directly talk to ovary, come on, get on with it, become the bride, go and get married. So you're just causing multiple follicle development and then forcing them to go to the fallopian tube. So that's what the reason at that time. Secondly, the time to get conceived was also projected as less if you go ahead with gonadotropin compared to letrozole or clomid at that time. We were not having letrozole at that time. It was clomid. We used to use tamoxifen at that time. Again, value of ovarian diathermy is very established value. Up to 30% of people with this alone can get pregnant. Bariatric surgery, if you come to this part of the world where I'm right now, Middle East, it's very common to do bariatric surgery for PCO in this country because they're happy people. They think eating late night and shisha is called definition of happiness. And that's how it works. So they're happily putting on every extra calories into their reserves. bank. So that's requires bariatric surgery. And then they come for IVF within 3 months. We object them because we can't do it with multiple nutritional deficiencies. You're not going to get anywhere. So they hate you, but there are commercially driven people doing IVF soon after the bariatric surgery. So is there a stress in PCO people that you need to address before you succeed in treating them? Yes. If you take any Ayurvedic medicine, lately since '89, I've been extending my knowledge into understand yoga and spiritual science, science of spirituality and science of yoga. I do believe there is Adi, which is agitation, which I mentioned to you. The GnRH pulsatility is high. It's a classic glossary called Adi, which is agitation that leads to higher LH pulsatility. Now, same, does stress, which is the agitation of the neural activity, normal brain activity is 54 to 64,000 neural firings that happens in a human brain, according to best scientists in Europe and USA. Now, within those pulses of brain impulses, if it is hitting the LH to fire more, consequences are obvious. But it seems that that nervous system neural hyperfiring affects endocrine system, which we already know. PCO is an example. That affects immune system. And that affects mental and physical illness. So if you see a lot of PCO people, the compliance is extremely poor, extremely poor. You tell somebody to lose weight, then you will do IVF. They just hate the doctor because they are showing on their face what they are what they are incapable of for the last 6 months. Husband has been telling, mother-in-law has been telling, sister has been telling, television has been telling them, 20 people has been harassing them, and then the IVF doctor also harasses them. That's it. They go to another IVF clinic. Now, IVF clinics are very smart. They don't discuss weight loss. Even 30 to 50% low pregnancy rate, you do it because you lose the business. Okay, I'm an algorithm person. I have 550 algorithms to follow for a fertility service. Of course, some of them are for PCO. Anyone interested, I can share with them. So I just use this algorithm, one in the folder, one to the patient. Any intervention, number of visits, medication, hormone testing, urinary ovulation prediction KISS testing. If you want to block the premature LH surge, I use indomethacin sometimes, cetrotide sometimes, clomid sometimes. Nowadays we use cetrotide more often because of the guarantee, but it's costly. So there are different ways you take the monofollicle or controlled ovarian stimulation so that you can do IUI and get a success of 15%. While you're choosing to do IUI and PCO, please, at least from 2017 literature, please pay attention to the literature that's getting available now. Even up to kind of 25 to 32% of people, according to Andrew Estew's data, have high DNA fragmentation despite having normal WHO criteria of 2010 with a perfectly normal semen analysis. And if there is a borderline mild, moderate, severe oligostenospermia, the DNA integrity might be much, much worse. If you see a normal semen analysis and you did an IUI, you may get 1.5 pregnancy rate, and another patient looks the same and sperm looks normal, you may get 19%. These are the people, the difference is in the DNA integrity. So if you have DNA integrity, which is abnormal, your IUI success rate is likely to be less than 2%. Be mindful. Same applies to IVF success rate is so negatively affected by higher DNA fragmentation. Just an example. Classically, we use antagonist protocol in PCO people to reduce the risk of ovarian hyperstimulation syndrome without compromising the success rate compared to agonist protocol. On the other hand, the cost, I will show a slide, which is at least 30% higher. So we need to be careful. As I said, I follow the algorithms for the patient. And I just want to say there are so many recommendations. We'll just touch base. What are all the adjuvants you use along with standard ovulation induction drug or control ovarian stimulation drugs? Metformin comes on the top of the list. And if you think antral follicle count is very, very reliable, please check. You wrote some antral follicle count in PCO in the beginning. Maybe you wrote kind of 20 per ovary. You may get more. So my record in in UK has been 55 eggs. I had one baby only. Rest were didn't even become blastocyst. The other lady was 64 eggs. We only had 3 miscarriages from that lady. The highest that I collected in UK in PCO, this was in Northampton, KIEL Fertility. She's a Nigerian, very obese, and somehow the drugs were given to such a level. We didn't get the estrogen testing for whatever reason, holiday, bank holiday, specimen missed, whatever. The day I went in, because I was doing a locum, I was just doing the egg collection list that day. Somebody showed me the estrogen value of kind of 6,000 picogram. That's all I knew on the day of trigger. So I landed up in starting a collection for her. I collected 74 and I could not see the tip of my needle. There were plenty of follicle. I stopped my collection. We made 52 blastocysts. And then I don't know what happened because, as I said, that was a short-term job in that particular unit. So this is what IVF clinics can end up. On the other hand, you may underestimate the antral follicle count and you may get more eggs. You may overestimate my antral follicle, you may get less eggs, because with the fear of giving less dose, you may get less eggs. People say, doctor, you told me I have 24 follicles. I only got 4 eggs from you, because I was scared. I was scared that she will sue me, but I didn't even give the minimum number of eggs. So this is just an apprehension, lack of experience, or lack of, trying. So be mindful. If the same clinician does antral follicle count and he measures his M2 for the next 100 to 200 egg collections, this is the only one can improve. Please be mindful of the fact. How soon you treat PCO people? And sometimes within 6 months, you may have to treat them. What is the cumulative pregnancy rate with ovulation induction? 70%. Pretty good. I will never try IVF in these people. Ovarian drilling, 50% success. Finally, only 1/3 of the people need IVF. Very heartening slide. Please remember this slide. Very heartening. How do they work? If you're using the approach to the patient in this way, it works wonders, which is A, be the ABCD. Everything should be in a simple way. I love the ABC of different publications in British Medical Journal. I was growing up developing fascination to go and live in UK or study in UK. Everything there was ABCD, ABCD of angina, ABCD of arthritis. Then I read this first one, ABCD of infertility for GPs, ABCD of secondary care of infertility. So there is a systematic orderliness according to the level of expertise that you have and the type of patients you should be treating, whether it's the primary care setting, secondary care setting, or tertiary care setting. So lifestyle management followed by psychological confidence building with the patient, becoming a team member. They should trust you. You're going to be their family member or kith and kin or the friend until they complete their family. That is the level of motivation you should infuse, inject, maintain, and nurture. Then medical management. So it is C, not A. That includes ovulation induction, control ovarian stimulation, nutrients, vitamin D, thyroid function management, weight management, insulin management, all that jazz. Then surgical management. What are all the vitamins in? There are many vitamins work, because without micronutrients, macronutrients go for a toss. Is there a value in reducing the overweight? There are countless reasons, countless publications, the rationale, how much beneficial to reduce the weight. Is there a proof after reducing weight, the live birth rate will improve? Yes, there is a proof published in major journals. So if you're using Clomid, what is your expected success? 75 to 80% success with 6 to 12 cycles. At least 1 to 2 cycles you monitor them. In resource limited places, in UK, we are not allowed to give ovulation induction, any control ovarian stimulation without system for monitoring. Otherwise, you will be audited, you will be blacklisted. Okay, so, but then there are reasons in other countries where you may have to be flexible and adaptive. So if you think after giving two doses or 2 cycles, you brand them as Clomid resistance, think twice. 85% of people are not Clomid resistant. Mechanism of action of Clomid, we all know, it works. It requests the pituitary hypothalamus axis to produce more FSH and a little bit more LH. Is there a difference between clomiphene and letrozole? If there is an increasing evidence, letrozole is going to take a lead role compared to Clomid, as you can see, is 1.6 relative risk odds ratio compared to Clomid. But similar OHSS rate, similar miscarriage rate, similar live birth rate, almost similar live birth rate to ovarian drilling. So, but it's a bit more costly. In this part of the world, we are only using letrozole for two reasons. One is the cost is low, but then there is a relatively better success rate. And secondly, endometrial thinning incidence is a bit lower. You need to have patience to go up to 6 to 9 cycles to get up to 75% ovulation rate, gestation rate of at least 50%. Patience and patience and patience. That comes from compliance and compliance and compliance. If in case they don't respond within 14 days, keep going. You don't need to induce menstruation. That's called stair-step protocol. There's enough publications on that. Very rarely you need to use 200 milligram dose. In PCO people, 85% of the people, the maximum dose of 150, they should ovulate. Minimum side effects, well, not minimum, but multiple side effects. If you add all the side effects, is around 41%. Should you add metformin? Yes, we routinely add metformin for improved outcome, and also in IVF to reduce the risk of ovarian hyperstimulation syndrome. Yes, there are studies coming up, 2 studies in Karunakar, rosiglitazone in 1 study, pioglitazone 1 study versus placebo. They're still inconclusive, so we don't have high quality evidence on this. So the risk bias is extremely high. I know I'm fully aware of medical reps. We don't have medical reps in UK, but we have them in UAE. So I'm just being attacked by reps to say, this does wonderful things. Take home baby rate is 80%. You need to be careful. How do they affect? They have very strong influence on the endocrine intra-ovarian testicular dominant environment. So there is theoretically beneficial role, but large trials are missing from credible authors. So if you want to say metformin addition has changed a dramatic difference, if you're adding, if you go to the gonadotropin now, should you add metformin to gonadotropin? We already put the efficacy is valuable with ovulation induction with tablets. Now you're going to gonadotropin. If in case you expect a live birth with 27% with gonadotropin alone, particularly FSH, you may land up by adding metformin 32 to 60%. Obviously, it looks beneficial. And this is again 2019 meta-analysis. Urinary versus recombinant. Live birth rate with urinary derived FSH is of 16%, with recombinant FSH of 13 to 28%. Now, 16 to 28% without taking into account of male factor, tubal factor, obesity, endometrial factor. These are all very, very low quality evidence. I already mentioned any discussion that I'm doing today is very low quality evidence. They are not high quality. They are not gospels. So there is little or no difference in live birth rate, incidence of multiple pregnancy, clinical pregnancy rate, miscarriage rate between urinary gonadotropin and recombinant in PCO, full stop, which means in UK, in Infertility, which is, we used to do almost 5,500 cycles long time ago, almost 250 to 280 cycles per month. Our gonal F usage was less than 15%. We were never found ourselves inferior by using. The latest data these companies are fighting with each other are 10.6 versus 9.4 oocytes. 9.4 with urinary gonadotropins, 10.6 oocytes M2s with recombinant. It did not translate into excess live birth rate. It's just the number of eggs you're getting more. I don't know whether the patient minds 9 eggs, 10 eggs is a difference in giving live birth rate. Yes, up to 15, there is enough evidence from Sunkara publication from HFEA that up to 15, there is an increase in the live birth rate. But that profile of the patients are different. This profile, this study group was different. So we should not jump from one data to the other. That's bias. Lean PCO is not different compared to healthy controls. Yes, they have a difficulty, but we can't ask people to put on weight. Particularly these lean PCOs they're against putting on weight. And so you lose them. So just be mindful. They're not much different. Of course, the dose that you give will be much lower than the tailoring of the dose has to happen. In vitro maturation, is there any role? at least to my knowledge now, there is limited evidence. Tim Child in Oxford Fertility Center is the major protagonist of this option in EVM. And there is one brilliant embryologist who owns a IVF clinic in Chennai. He's another protagonist in India. He's even, last week I spoke to him, he regularly does IVF. He's happy because people are saving money on their gonadotropins. Complications are low. As an embryologist, he can run as a gynecology service by doing IVF. You just need to look after the eggs. Somebody collects and gives it to them from unstimulated follicles. So yes, there is a role, and there is a someone who is a special interest and continue to do it. Once these 6 ongoing trials reports come, we'll be a bit wiser to know how many more people we can offer IVF. We all know by tweaking some pearls in a 10-pearl necklace, we create GnRH antagonist or agonist, and they work to block the LH surge. That's all. Antioxidants, there is a very low quality evidence, it helps. There's a big list of antioxidants, as you can see: N-acetylcysteine, melatonin, L-arginine, myoinositol, dichloroacetal, carnitine, selenium, vitamin E, vitamin B complex, vitamin C, vitamin D, calcium, CoQ10, pentoxifylline, omega-3, and so on and so forth. So compared to placebo, there is a very low quality evidence, which means you could have helped 20%, but then you may land up in helping 26 to 43% if you're putting so many things. But what price? How much of this have got a good bioavailability? Which brand you use? I leave it to the discretion of the clinicians practicing in your own place. One caution of advice with pentoxifylline, as you know, people use it as a fibrinolytic agent in burns. Plastic surgeons use them all the time. I use them for thin endometrium people, but expected miscarriage rate of 4% would go up anywhere between 2 to 15%. So I dare not to use this one in PCO. I'll just quickly go through different trace elements, which works not directly on a PCO, but works on insulin resistance. But if we think insulin resistance is one of the contributing factors for abnormal pulsatility of GnRH, then you should get indirect benefit by using these agents. That's all I can claim. 200 milligram of selenium, 220 microgram of chromium, zinc, 220 milligrams daily, 1000 milligram calcium and 50,000 per week of vitamin D for 8 weeks. Folic acid, of course, we have to use anyway, but you're using longer period rather than periconception period. Chironacetal, I think they come as a standard dose. We use Overcube brand in this part of the world here. Then omega-3 fatty acids. Well, I do take them because I don't like the smell of fish, so I'll end up in using them. And so I encourage everybody to take, because we are to start with, we came from water. So I have no reason to think the omega-3 will of any doubtful value in PCO. So it should be a regular ingredient. And there is enough evidence to say normalization of the menstrual irregularity. I would say these are all miscellaneous, vitamin B1 and all. So if you go again, specific slide for inositol, if you think a pre-treatment IVF, we have expected live birth rate of 12%, the rate among the women using myo-inositol would be between 9 to 51%. That's why this data is making myo-inositol getting more and more popular, but the evidence is low quality. Again, there is a trend that reduction in the miscarriage rate. So if the background risk miscarriage rate is 9%, it can be brought down to 2 to 8% in those people who put them myo-inositol. As in vitro maturation, we already covered. Laser laparoscopic ovarian drilling, yes, live birth chance with ovulation induction, let's say 42% versus 28 to 40% with laser ovarian drilling. But its ovulation induction could have been 6 to 9 cycles. This is fast-paced world these days we are working in. So there may be a distinctive role. You may have to be more liberal with laser laparoscopic ovarian drilling. Obviously, other merit being almost no risk of multiple pregnancy, iatrogenic with the drilling. This is 2020 literature of Cochrane, so we can't downplay that. But quality of evidence is low. How do you reduce the risk of OHS? Just blindly treat PCO with gonadotropin, do IVF. Colleagues will receive people with OHSs. So there is a ritualistic protocols to minimize the risk of ovarian hyperstimulation syndrome. Generally, antagonist protocol, agonist trigger, lowest dose possible, correcting metabolic dysfunction beforehand, and try to avoid doing fresh embryo transfer and use cavagolin. And if in case you land up in even freezing embryos, still you think estrogen levels are high and she's symptomatic, you can continue the antagonist or you can reintroduce agonist. Somehow you need to cause rapid, aggressive luteolysis because estrogen is the culprit. The final agent that will cause fluid leakage through VEGF is estrogen excess. All right. So freezing all embryos, your unit should be good enough to vitrify and thaw them with highest quality embryologist system, embryologist attitude, skill, training. Otherwise, you make a mess of her embryos. You saved her, but you're not going to make her pregnant. Please understand, they came for children. You are worried about OHSS, but she's not worried about whether OHSS or not. Even if you didn't cause her OHSS, if you don't give her pregnancy, you are a failure as far as she's concerned, or by definition of failure of ART is concerned. Volume expanders, definitely role is there because you're taking away the albumin by doing ascitic tap, put the albumin back. Plasminogen activator inhibitor mutation prevalence is high in PCO people. This is just a coincidence. Inflammatory markers are higher. Everyone knows adiposity, fat cell being asked to do wrong jobs become, the neutrophil asked to do wrong job becomes adipose cell. So that is a kind of inflammatory reaction. I do endometrial immune profile lately to understand immune dysfunction within the uterus. Of course, I manage people with recurrent implantation failure, miscarriage, and care fertility, which is a referral center. There are only 3 or 4 centers in UK. At the time when I was there, 2010 level until 2015 regularly, that we used to take on 10 IVF failure, 5 IVF failure. So this couple, they're not just coming for PCO with 5 IVF failure. We're talking about that. Or PCO with 3 miscarriages and 2 implantation failure after transferring euploid embryos. So you always go that extra mile with this couple. Take the expert's opinion, read the gray literature, take a consent that these are all gray areas, then do that extra step because these people have nowhere to go. Now, pregnancy complications, it's outside the scope of this discussion. Does PCO because of excess LH causes recurrent miscarriage? Evidence is limited. Does extra testosterone is responsible for excessive prevalence of miscarriage? Evidence is limited. Just looking at PCO, does it increase the risk of marriage? The answer is no. Is thin women PCO abort more than high BMI? The answer is no. High BMI people abort more because obesity itself is an independent risk factor. Age is an independent risk factor compared to endocrine dysfunction. But endocrine dysfunction, making endometrium look miserable, is going to cause miscarriage no matter what. Whether you like it, whether there is a class A evidence or not, it's going to happen. Is metformin is going to reduce the risk of miscarriage? There is a low quality evidence available. Does PCO present you with epigenetic abnormalities? The answer is yes. There are times where we did 9 stimulation. Either we got hyper response, we abandoned, or we did not get any oocytes. We got all GVs. So it took 9 IVFs to get 1 baby in Bone Hall, Cambridge. This was between 2001 to 2008 when I was there. And there are times where we have to do ovarian drilling after several failed attempts to do control ovarian stimulation to get a decent response from the ovary. Otherwise, ovary was either maniac or depressive. It's MDP, right? And we are not in control. Many psychiatrists struggle to control MDP, and many gynecologists struggle to control resistant PCOS. So we did ovarian drilling, followed by a bit of response and a child for one lady after 4 or 5 failed stimulation. Never ignore non-PCO infertility, may be there. So overall, I'm coming to an end that they may just be sufficient to give luteal support, because if you take it, 98% of children on planet Earth are born without seeing a doctor. Therefore, there is something right with them. do what is right with the people who are delivering children without seeing a doctor. What they have, you know what is normal, ovulatory, pregnant cycle, endocrine changes. Just mimic all of them. Make sure the man is doing a man's job. His sperm is normal, DNA integrity is normal. He's having regular sexual intercourse every 2 days. Tubes are patent. Ideally, you check the tubes with ultrasound-based tube tests so that you can see the fimbriovarian alignment, which you will never see outside the laparoscope with a HSG. So that's the new thing. I stopped doing HSG, having done making so many enemies in Allen Institute. We moved on to ACOSI, air contrast salpingography. So luteal support only, or luteal support with ovulation induction with IUI, control ovarian stimulation with IUI, IVF with genetic screening, yes or no. Endometrial improvement is a paramount important. So that's why I start with mid-cycle scan. It doesn't matter whether I'm giving any sum of FELP. I start with assessment of B and if possible C. Again, reverse diastolic flow is the only one I adjust with aspirin and sometimes vaginal Viagra, just until a positive pregnancy test. Thrombophilia screening, if you're in a teaching hospital, you have a luxury of doing a detailed thrombophilia screening, both for genetic and acquired causes. Otherwise, you will have limitation. Again, immune intolerance, you may not come across that 5 IVF failure with PCO or 5 miscarriages with PCO, but you do come across this, you need to open doors for this investigation. And there's a definite role for ovarian diathermy and bariatric surgery. As I said, I have a lot of algorithms and flowcharts to share with anyone interested. I stick to the basics. This is the nice guidelines, how you approach a couple with infertility with or without PCO. Standard, very standard, approach remains the same. Diagnostic workup, treatment page. So let's not be biased that we know how to manage. We only get to see our ego-based medicine becomes instead of evidence-based medicine. Whosoever is listening, whenever I listen to something, I have to learn something. I can't go with this kind of concepts in my head. I won't get anything. And be mindful. Many patients are leaving one IVF clinic to the other, one gynecologist to the other, because Google doctor says they didn't do endometrial scratching for you. That's why you're not getting pregnant. They didn't do acupuncture for you, you're not getting pregnant. But nobody doesn't want to listen. No obese PCO want to listen that everybody wants them to lose weight. No, we all listen what we want to listen. That's called mind. Mind is the emperor, mind is the king, and mind will do what it suits. It applies to the doctor, it applies to the patient. So people are leaving because they don't get what they want from you, particularly if you ask them to lose weight. So you need to have a very clever approach. They should feel you are their family member or a friend. So care of PCO should start in the puberty. In my opinion, our lifestyle is poor. So if you look after the preceding 10 years of before you see them in the infertility clinic, your half battle is won already, because they don't have severe metabolic dysfunction. They're fit. They go to gym. They don't smoke. They know how to take care of their metabolism. They know how to eat, what to eat, when not to eat. Not eating biryani in the night, 10 o'clock, and sleeping at 10:30. That doesn't work. And that's very common in many parts of many people. Embrace the patient. Probably she will, once they trust you, they will be with you. Thank you.
So thank you, Dr. Karunakar. Anyway, after recollecting your nostalgic journey at AIMS and a small stint at Maulana Azad, this was really a wonderful and exhaustive and a completely insightful look into the infertility and PCOS and a holistic evaluation. So I think what you brought forth was keep your objectives very clear, do a holistic evaluation of the patient, and be realistic in giving the figures, which should be your live birth rates rather than your pregnancy rates. I think that's very important what you discuss with the patient. And it's very important to realize when and where to intervene and when not to intervene. So do no harm. And your stress on catch them when they're young is very important. Yes, because 10 years of disease is definitely going, untreated disease particularly, is definitely going to add to the morbidity and is going to make things difficult for us. I'm very happy that you again reiterated the concept of taking a detailed history. which not only gives us clues about the various aspects of the couple, but also establishes the rapport with the patient. And we must realize that PCOS itself is a wide spectrum. So even in that, you have to identify the point of disability and address it rather than just treating the disease. It's the patient which we have to treat, the couple which we have to treat. So I think it was very comprehensive, and we are really blessed to have you. You have really added a lot to us. Thank you so much.
Thanks, Dr. Karunakar. That was a really very exhaustive and informative scientific deliberation from your side. And you have nicely talked about one-stop fertility center while you're treating your patients. It's not only the drugs or the surgery, it's the patients who need to be treated and they want life work. That's the end of the patient's desires. One thing I would like to tell that these patients, they switch over from one infertility center to the other infertility center very quickly. They are sometimes very desperate. And what happens, they do not tell the past history. We get quite a few patients who have been getting ovulation inducing drugs 18 times, 20 times. They have been switching from one center to the other center, and then they land up with ovarian malignancies. We have seen patients of PCOS landing up with endometrial cancers as well, because these patients, they're so desperate to have children, were so desperate to have babies. They switch over from one center to the other and they conceal most of their past history. They do not tell about their treatments that they have taken. This is one thing which I found lately very relevant in today's scenario. Thanks, Dr. Karunakar, for enlightening us on many aspects of PCOS.
So,
Thank you, sir, for such an amazing talk. And so, as always, so much to learn from you, sir. So we have few questions. If everybody permits, we will take those questions now.
Is it in the Q&A or in the chat box? Where is it?
Q&A, sir. So
Okay.
how do you assess ovulation in PCO-IUI patients? That's the first question by Dr. Rupali.
Yeah, first you know the timing. Typically, if you give ovulation induction with letrozole clomid day 2 to 6, it's very well known. Majority of them ovulate a week after completion of the last tablet. And then 36 hours before you expect, like day 13, you just go 2 days before, that's when you expect LH trigger. Either you do urinary LH trigger, or you have the facility, you can do blood, or you could have done ultrasound to get a rough idea. The follicles are heading towards 16 to 20 millimeter follicle age. So ultrasound, blood test, urinary test, and also logical timing, because you may not have the option for any of those three.
Thank you so much.
Always document ovulation, or you after trigger just do a IUI without documenting ovulation?
I never had to document ovulation. I trust HCG, Ovitrel. And secondly, there is no way to confirm ovulation by doing scanning. Many a times I don't see a ruptured water bag and collecting in the pouch. It's only 2 ml. It's easy to miss 2 ml of fluid in the pouch because POD is very big, and to miss 2 ml is very, very common. And unless you put the head up, I'm not sure how you can see 2 ml of liquid in pouch water glass. So scientifically in UK, there is not a single instant. Nobody ever taught us. It's not in the Royal College guidelines, BFS guidelines, ESRM guide, and never. But this question comes 1,000,000 times from India or from Nigeria or Africa.
And do you believe in single IUI, sir, or double IUI?
Belief system has gone long time ago. There is no belief here. It's the evidence. And extremely low quality trials have been done with double IUI. If 20% and 2% is the clinical pregnancy rate with the same sperm with a higher DNA integrity and low DNA integrity, how are you going to actually? So unless everyone universally start introducing DNA integrity test, we are not going to compare success rate difference between one IUI and two IUIs anymore. It's impractical. The difference is massive. 10 times difference is the pregnancy rate. This is not a small data. These are the top 3 andrologists in the world. Peter Schlegel is the president of ASRM. Andrew Estevez, I would say he's the top 5 andrologists publishing. In his sleep, he's publishing, right? And I'm talking about those guys. The areas where that I've not done a research. On endometrium, I can talk authentically. Endometrium and implantation failure. I have the world's second largest data. But if I have to go to the semen integrity that gives IUI success rate, I have to go to the people who are spending 40 years doing the same thing. We have to follow the excellency, not personal prejudice. Yes, we can go to the next question.
Yeah, so we have a message from Dr. Gauri. She says, I resort to social prescription where I ask women to draw on the first visit. They are skeptical but draw. Their chemistry and compassion becomes vivid. I introduce increase in DMT by encouraging them to revive their creativity. It works well. Cognitive bias and spotlight consciousness is diverted to flood consciousness. They respond better.
Dr. Gauri, unless you win the confidence of the couple in front of you, what is in your brain that's not meaningful to the person in front has no relevance whatsoever. So that is the definition of teaching. Teaching, a good teacher or good prescriber, good provider has to make meaningful contribution to the couple in front. So once they have that meaningful attachment with you, they will take everything on. It's not about what they're not doing right. We have to do something right as a prescriber. Do you regularly measure insulin resistance? In UK, it's not a practice at all. What is your opinion on luteinized unruptured follicle syndrome? As I said, I don't look for an unruptured follicle, so I never had to manage one because I was out of this domain. Same, all of my UK colleagues. Now, the thing is, if I've done 10,000 egg collections and I've given trigger and 10,000 times I find the progesterone is raising on the day and oocytes are coming from most of the follicle, why would I think something called luteinized unruptured follicle syndrome is there? See, and measuring follicle leak is impossible. If you see ovulation YouTube videos, some of the scientists have captured them. It comes like a drop of sweat on your forehead. How are you going to capture it with a black and white ultrasound scan? So it's limited.
Okay, so we have one question in the chat box sir, could you please elaborate about the role of omega-3 fatty acids in infertile patients with PCOS?
As I said, we grew up as fish before. We were in water and we became fish and then reptiles and amphibians. So I think every epigenetics is dependent on antioxidants, and omega-3 comes as one of the leader contributing antioxidant for every organ that we have. So, and unless they have vegetable source or fish source and eating all the time, like 3 portions of fatty fish throughout their life, there will be some deficiency. So I will make it a point, we follow our great ancestors' diet, or what we call them Stone Age diet. So I insist upon fish-based or non-fish-based omega-3 fatty acids to be in the system.
So one more thing about inflicting local injury in the endometrium. So what does the evidence now state, whether it should be done, and which all cases of recurrent implantation failure do you suggest doing endometrial scratching in the previous cycles?
Okay. It's a recurrent implantation failure is one of the favorite topics, with my background being in St. Mary's and in care. The only indication which stands, if you have read 2018 fertility sterility towards the end of the year, there was an editorial debate. Half the people criticizing why the hell we are doing endometrial scratching, half the people uplifting it. And this is the same. Like there are 2 parties in a country, one will blame the other. The only indication that I found was that if you think immune system within the endometrium, which is called uterine endometrial immune profile, this is the reference I'm showing. I hope you're able to see the slide. So if you send an endometrial sample in the window of implantation to USA Chicago, Rosalind Franklin Reproductive Immunology Lab, they'll give the report. They will say low immune activation, which means you have gardeners which are supposed to prepare the endometrium to an implantation friendly, rotating the soil, softening the soil, removing the stones. You are just making implantable endometrium ready. That is done by white cells. The name of those white cells that prepares the endometrium to cause successful implantation is called uterine natural killer cells. It's just a misnomer. All right. Now, if they came, they have less in number, they have not been trained enough, they have not been induced, they have not given enough tools, they will be lazy immigration authorities there, okay, or lazy gardeners or incompetent gardeners. They cannot do anything useful for the roots to establish properly. In those cases, immune stimulation is recommended. The protocol that includes immune stimulation within the endometrium is local injury, the cycle before, mild stimulation, replacement of frozen embryo, not in a fresh cycle. You must do natural cycle. Luteal support should be with HCG and exposition to seminal plasma. We ask husband to have intercourse every 2 days from the stimulation phase in the frozen cycle and even after the embryo transfer. So sperm is one of the most potent antigen human species knows, and that is the known inviter of uterine NK cell, which prepares the endometrium, which induces implantation markers, which are essential for implantation. This is about understanding normal implantation. So this is the only case I do. Is that answer clear enough?
I didn't understand one thing. So you said having intercourse after embryo transfer in cases of recurrent implantation failure, that seminal plasma will evoke certain, it will give certain positive waves or improve the endometrium. How did, something you stated in your last a few lines. So,
yeah, so that's what I'm trying to explain. If you believe uterine NK cells are fundamental implantation cells, you need them more in number at the time of implantation. And I don't know if my parents were having intercourse when I was implanting. All villages, all great, everybody, nobody stopped having intercourse on the cycle we have been implanted. Because that's the only thing the ancestors do, villagers do. They sleep together in a single space that they have in a single hut. So it's not unscientific or unphysiological. But there is enough evidence now how the sperm induces uterine NK cell. There is plenty of research on this.
So there is one question on luteinized unruptured follicle.
Yeah, as I said before, I never had to manage luteinized unruptured follicle syndrome, never seen one. So if you think follicle you saw, but you know somehow it's unruptured, the evidence of unrupture is, if you think you can demonstrate corpus luteum or follicle, I'm struggling. I've been scanning since 86 in AIMS onwards. I'm obsessed in scanning, but sometimes I fail to recognize early luteal changes in a follicle. Very difficult for me. So I can't answer that question if that entity exists.
Sir, you said that the cavagoline may be used around the time of trigger to avoid OHSS. Sir, how do you use it?
Yeah, this protocol is generated by Carl Simon's group in EV, Spain. If at all there is one IVF unit which has a maximum number of publications every month, it's EV in Spain, Valencia University, Roma, and so on. They have done the maximum research on humans on how this cabergoline reduces the severity of OHSS, operating through reduction in the expression of VEGF. The dose is 0.5 milligram once at night in the middle of a main meal. On the day of trigger, you give it for 8 doses. Or if you are giving on the day of egg collection, because you could not predict that many follicles, after egg collection only you realize you went into 30 follicles, you'll end up in getting 30 eggs. Yes, you know the risk is gone up. Then you give it on the day of on the day of egg collection for 6 doses. And it is known it can reduce the severity by 50%, not 80%, not 90%. But you must explain to the couple, they can feel like a zombie. Very, very dizzy causing drug that I've ever seen. 2 reasons for that. It's very potent, it's a dopamine agonist. Dopamine is, it can give you salvation, if you want, if you take dopamine. It's very, very toxic and potent. Now, you're taking a medicine that's been designed pharmaceutically to last for 7 days, and you're taking it every day.
Right.
An average brain will struggle. But somehow these people are already zombies because you stimulated them. Estrogen is whatever. And women's femininity is so powerful that they take on anything. As men, I don't think men can take that much cobergolin, but women do all the time successfully.
Sir, I have a doubt. Actually, in our ovulation induction for even IUIs, sometimes we get many follicles. And though the evidence says that after 2 dominant follicles, you should not be doing, if you have 2 follicles, 18 and more, you should not be doing a IUI, or you should not, the couple should even abstain so as to avoid multiple pregnancies. Now, in these cases, can we give cabergoline? Suppose, I mean, if the patient, they don't listen to you and they may be having a normal, they might be trying normally, you might have deferred the IUI based on the evidence saying that, okay, you have 3 dominant follicles, we should not be doing your IUI. But can we also give them a cabergoline so as to avoid hyperstimulation in these cases?
Can I explain to you one way scientifically? In my experience, because we do endocrine workup all the time in every case, so I must have seen maybe 20,000-30,000 cycles, track record of monitoring. Unless the value is 3,000 picograms or more, the chance of developing OHSS is I haven't come across in my life. Now you're giving letrozole or whatever you have been to produce IUI. Why do you expect estrogen to be 3,000 picogram? There is something missing here. So don't give when the estrogen is not even touching 1,000. Doesn't make any sense to me. Is that clear to you?
Right, sir.
Right.
So we document it after doing a E2, and if it is high, then only, otherwise there's no point.
I don't come across people developing hyperstimulation to cause ascites, pleural effusion without estrogen reaching a pharmacological levels of 3,000, which is 10 times more than a monofollicular levels of estrogen.
There have been cases, sir, even with ovulation induction with clomiphene, these PCO patients do sometimes land
but
up
when
in
you are not monitoring estrogen levels,
Mm.
you haven't monitored estradiol level, because estradiol levels can be 3,000 with 20 follicles at the level of 12 millimeter. Please understand, I never mentioned size of follicle. You raised the point. I never going by your statement also. Brain doesn't know. VEGF doesn't know the size of the follicle. They are not scanning. They react to the chemicals. You must measure estrogen to decide who is at risk, not the size of the follicle, not the number of the follicle, because there may never be a single dominant follicle in polycystic ovary people. There may be 40 follicle at the size of 12. Estradiol levels will be 5,000 picogram. You are in a disaster phase if you are looking at the ultrasound machine. It's incomplete clinical approach.
Ranjana ma'am, Asmita ma'am, Sangeeta ji, you want to say anything, Mala?
I expected 100 questions.
Sir, your lecture was so clear. It was complete Gita. I must say, you explained Saregama of conception in such a great detail, and orchestra of endocrinology in PCOS was so finely handled by you, sir. You made it so simple and clear to all of us. So that was excellent. Anybody who wants to add anything? Guest of honor, chairpersons, please. So since we can give vote of thanks. So over to you, Payal. Thank you so much, sir. Thank you so much for being with us today. Thank you so much.
It was a wonderful lecture, really. And the thing is, it was very comprehensive. The thing you said, all these algorithms are available to us. So how do we get those?
Just email me, marikinti@gmail.com. It was in my
Could you
first
just
slide.
tell us your contact details, or I can get from Anita?
No, marikinti@gmail.com. It was in my...
I'll share sir's email with you, ma'am.
All right.
Yeah.
Ma'am, I'll share with you his email. I'll share with you. It was in the group also. I'll share with you.
Yeah, it's there on the screen now.
Yeah.
Marikinti is my surname at gmail.com.
Okay. Thank you.
So I don't know about the audience. There's plenty of 51 people participants. They don't have any questions?
So they were around 80, more than 80 at one time. And everybody's so happy. And
Because your
they
lecture
must
was
have
so
learned a lot.
comprehensive, very
Yes, sir.
informative. So all our doubts have been cleared.
There are a
Yes,
lot
That
of
is why there are very
compliments,
less
sir.
questions.
Don't you think we are biased? It may be that they never understood anything.
No, not at all.
No, no. So one
So-
more
It
question
was
is
very
there.
explanatory, sir. Very explanatory.
So my
Let's
personal
start.
thanks to you, Asmita ma'am, Ranjana ma'am, Mala, Sangeeta ji, and Jyoti. Thanks for being always there for